Hello everyone. So in our last class we discussed about the use of oxytocin in labor in a primigravida laboring lady. Today we will talk about its use in a multigravida laboring lady. For primigravida we put whole ampule of oxytocin in 500 ml of NS, that makes the concentration as 10 milliunits per ml, and then we start it at 10 drops per minute, that is 5 milli international unit per minute, and we increase the dose at 30 minutes interval. So that was for the primigravida patient. For a multigravida patient, we do not do it this way. We do it in a different way because here we use low dose regime of oxytocin infusion. For this, we first need to dilute our oxytocin that we have in our oxytocin ampule. It has got 1 ml solution in which there is a 5 international unit of oxytocin, but we need to dilute it. How do we do it? We take this 1 ml in this syringe, 5 ml syringe, so it has 5 international unit in 1 ml. Then we dilute it with 4 ml of normal saline or distilled water, that makes whole of it as 5 ml, right? And in this 5 ml there is 5 international unit of oxytocin, so the concentration is 1 international unit in each ml. So this is how we first make the solution, and we always label the syringe as 1 international unit in 1 ml, right? So in a multigravida we will not be putting whole of 5 international unit of oxytocin at once in 500 ml NS, but we will only be putting 1 international unit of oxytocin in 500 ml of normal saline. So we have put 1 international unit or 1 ml of this solution into 500 ml of NS, that makes the concentration of that NS bottle as 2 milli international unit per ml, right? And what is the initiating dose in a multigravida? As we use low dose regime here, the initiating dose is only 0.5 to 2 milli international unit per minute, and the concentration of our drip is 2 milli unit per ml, right? So if we take the mean of 0.5 to 2 milli unit per minute, mean is 1 milli unit per minute. So in a multigravida, the initiating dose generally is 1 milli unit per minute, and in each ml in that bottle that we prepared there is 2 milli unit per minute. So we will only be starting half ml each minute, that is 10 drops per minute. So drop rate here is same. Drop rate of the drip that we prepared in a multigravida and that we have prepared in primigravida is same, right? But the concentration of NS bottle is very different. The oxytocin that we put in that NS bottle at once was 5 international unit for primigravida, but in multigravida it is only 1 international unit. So the concentration here of that drip is very low. It is only 2 international unit per ml, and the starting dose 2 milli international unit per ml, and we are starting with 1 milli international unit per minute. So we will be infusing half ml per minute, that is 10 drops per minute. So the drop rate is same, it is only the preparation of the NS bottle, the oxytocin drip, that is different in a multigravida patient. And what would be the interval? Interval here is slightly longer. In a primigravida the ideal interval is 15 to 20 minutes, but if we take it practically we may monitor it at 30 minutes interval, as it was a high dose regime. So we need to monitor more frequently. In a multigravida, as we are using low dose regime, we can monitor at 40 minutes interval. And what would be the incremental dose? Incremental dose would be same as the initiating dose. So 1 milli unit to be increased, 1 milli unit per minute increase is to be done. So it will be now 2 milli units per minute, 20 drops per minute at 40 minutes interval till we get adequate contractions. So the interval here is slightly different. Monitoring would be the same. We would be looking for the strength of the contractions, for the fetal heart rate. So this is how we should ideally be infusing oxytocin drip. not in the way whatever we like, whatever the sister on duty like, but there is a standard protocol to infuse oxytocin in primigravida and multigravida, and it is very different. It is basically the preparation of NS bottle that matters. The concentration of oxytocin that you have in that NS bottle is very important. I hope you all learned that. So my next part of today's discussion is to identify the complications. The most common complication of oxytocin infusion is contractions. Hypercontractions means there may be an increased frequency of contractions, or there may be an increased intensity of contractions beyond a normal limit. So that may be detrimental for the fetus. It may cause fetal bradycardia, right? That should not happen. That we need to monitor. So what are the normal frequency of what is the normal frequency of contractions? We all know it is 3 to 5 contractions in 10 minutes. The contraction should sustain for 45 to 60 seconds, and there should be a relaxation of at least 3 minutes between each contraction, right? So that is called as adequate contractions. But what is abnormal? There are 3 definitions which we need to know. One is tachysystole. Tachysystole is increased frequency of contractions. When we have more than 6 contractions in 10 minutes, it is called as tachysystole. Then there is another term as hypertonus. Hypertonus is sustained contractions for a prolonged period. So here the fetus gets compromised if the contractions are prolonged. So how much prolonged? If they are for more than 2 minutes. If one contraction lasts for more than 2 minutes, it is called as hypertonus. And there is third term, hyperstimulation. Whenever this tachysystole or hypertonus is associated with abnormality of fetal heart rate, then it is called as hyperstimulation. So these are the definitions under which you will be labeling your patient whenever there is a there is a complication from oxytocin infusion. So what to do if you get these complications? So whenever you see that you are getting this kind of complication in your patient, how to manage it? There are five immediate steps that you need to do, immediate measures. First of all is discontinuation of oxytocin drip. So you immediately discontinue the oxytocin drip. You ask for help. You tell your assistant to start a bolus RL infusion. Then you put the lady in left lateral position and start high flow oxygen by mask. That should be at least 10 liters per minute. And then you simultaneously ask someone to take the vitals of the lady, and then you will be performing per vaginum examination to see the color of flicers, to see the dilatation status of cervix, and most importantly to rule out cord prolapse. These are the 5 most important measures that you are supposed to take whenever you have complication or hyperstimulation, hypertonus or tachysystole if you are using a oxytocin drip. What if you do not get relieved even if you have used all these measures? The lady is still having more frequent contractions. Then there is a drug available called as terbutaline, which is a tocolytic drug. How do you give it? You take one ampule that has 250 micrograms of terbutaline. So you take 250 micrograms of terbutaline and give it subcutaneously to the patient. It immediately subsides the contractions. So that is the last measure which you are supposed to take. And if nothing is helping, baby is still in compromised status, you need to take her off for cesarean section. So this is all about the oxytocin infusion, its complications, and how you manage that complication. There is one more type of oxytocin infusion that is called as concentrated oxytocin infusion. Basically in this, the concentration of normal saline bottle is more because you want to give less fluid, still adequate amount of oxytocin. So it is given to the patients who are prone to develop overfluid, fluid overload. Right? So there are certain category of patients like hypertensive disorders of pregnancy, or patients with severe anemia or with cardiac disease. They are prone to develop fluid overload. So in these cases, you do not give normal concentrations or normal solutions that we use in primary and multigravida, but you use concentrated oxytocin drip. What do you do in that? You just double the concentration. In a priming gravida, instead of putting 1 ampule, you put 2 ampules of oxytocin in 500 ml. That doubles the concentration. But then you decrease the infusion rate or drop rate. You started with only, instead of 10 drops, 5 drops per minute, and then you increase it by 5 drops only, so that the lady receives less fluid, right? So there is something called as concentrated oxytocin infusion that I wanted to convey to you all. So this is it for today. I hope I conveyed use of oxytocin infusion in a proper way, and you all get take home messages properly, and you start improving your practices in labor room from now onwards. Thank you so much.